always nice to get someone. We love all the doctors over at Harvard, but it's not that often we meet somebody new from over there. So it's fantastic. I'm glad you're on today. Tell us about your background and how did you make your way to come here to this area and with Harvard?
Yeah, well, thank you for having me. I agree that everyone at Harvard's great. I'm a little bit biased, but I'm originally from Southern California, from the Inland Empire.
Okay.
And I left and did my college and medical school schooling in upstate New York.
Wow.
And then did my residency and fellowship training in Kansas City, so I've been all over the country.
Yeah.
Then decided to come back home, and I was practicing in the Inland Empire until recently.
Okay.
And delivered actually my daughter at Saddleback, which my room overlooked Harvard Eye Associates, and I said, you know what, it would be really nice to be closer to home. So here I am.
That's a good story.
Yeah.
Very good. And of course, you know, Harvard is expanding. They've got just great staff over there. Not just the doctors, but everyone that's involved. And
absolutely.
They really do some great work over there, and just good people.
Absolutely.
So it's great to have you with them.
Thank you so much.
So today we're going to talk about macular issues, and in particular, macular holes and puckers. Now I've heard of the holes, I've never heard of the puckers. So we're gonna go through this. And on the first slide, we're going to show, in the photos we're going to bring up, the effect of macular issues. Tell me first what we're talking about, macular degeneration, or what is that? What's happening?
Sure. So a lot of people are familiar with the macula in regards to macular degeneration.
Yeah.
I know you guys have talked about it on here before. So the macula is the centermost part of the retina, which is the nerve tissue in the back of the eye.
Okay.
When you look straight ahead at something, when you're driving, when you're reading, you're predominantly using your macular area to do that work.
Okay.
So obviously a very important area to the eye. Problems with the macula can cause problems in your central vision. So your central vision can either be distorted or blurred, like the picture on the left, or there can be a hole in the center of your vision as you perceive it, which we call a scotoma, like the picture on the right.
Okay.
And it's difficult just by your symptoms to know, is it macular degeneration or a different problem with your macula? The symptoms present similarly, and so that's why it's important that if you have any of these symptoms to come in to see your ophthalmologist. Macular holes can cause either of these problems, and typically macular puckers cause more of a distortion or a blur and less likely that little spot in your vision.
Okay, so on the next slide we're going to see macular holes. Now, am I hearing you right that this is different than macular degeneration?
Yes, it's a different problem.
I thought this was in association with, one and the same.
So it affects the same area of the retina, and the symptoms can often be similar, but very different problem, treated differently, different etiologies.
Okay. All right.
So this is a scan called an OCT, or optical coherence tomography. It's a very easy scan for us to do in the office. Just takes a couple of seconds and gives us very detailed information about the macular area and its anatomy. So these are two different examples of macular holes. The one labeled B is not quite as open and gaping as the one underneath, so it's not as severe of a stage. And the one C right below it is a larger hole.
Okay.
So basically what causes macular holes, typically it's age-related. So in the back of the eye, there's a jelly-like substance called the vitreous. When we're born, it's nice and solid, and as we get older, it can shrink. About 85–90% of the time, it shrinks without any problems.
Okay.
But sometimes it can cause problems when it's shrinking and detaching from the retina.
Okay. In
the case of macular holes, what happens is it kind of gets stuck to the macula, and that area stretches, and a hole can rip open. In the image on the bottom C, you can see that the little dot above the hole, and that's actually where the vitreous has detached and has left the hole underneath.
Okay. Now, you mentioned you do a scan. Is this something, when I came in like a couple years ago and had the whole eye exam, was that part of a normal eye exam where I know I looked into this device, or is this something you would only do if somebody starts to notice something?
Sure, so that depends on the doctor. Most retina doctors will do this as part of their scan because this is what we look at and what we see every day. And a lot of it is symptom-based. So if you come in complaining of distortion in your central vision or a decrease in vision, oftentimes we'll get a scan to help us corroborate what we're seeing clinically.
Okay, so in the next slide, we're going to look at puckers. Now, is this something sort of a folding of the back?
Exactly. So this is, again, another OCT image. You see it doesn't have that hole. I don't know if you can appreciate, but there's kind of that flat line on the top that's distorting the image, and that's the pucker itself. The etiology is pretty similar to what causes holes in that it's age-related and a problem with that vitreous. This time, the vitreous, as it's shrinking, can deposit some scar tissue on the surface of the macula, and that kind of will cause the macula to swell and be thicker than it normally is. With macular puckers, how thick the retina is typically correlates with how poor the vision is. And so sometimes it's pretty mild and someone may not notice that they have any problems, but in this case, you know, it's typically more thick, and so you would expect them to have a decrease in vision.
So with the puckers, is that if someone begins to notice something, that would be more of a blurred vision?
Correct.
Okay.
Correct.
And let me ask you, I know we're going to see this next slide here. We can kind of talk about this here, about how you solve this problem.
Sure.
But quickly, what is macular degeneration, if it's different from this? If you could just kind of go over that.
Sure, absolutely. So macular degeneration is when, again, problems with the macula, and it is age-related and very strong genetic component to it. And really, it's just that macula ages faster than it should.
Okay.
I like to tell my patients that if we all live long enough, we'll probably all get macular degeneration.
Okay.
It's like the macula just kind of wears down. And there's two forms. There's the dry form and the wet form.
Right.
Unfortunately, at this time, there's not a whole lot we can do for the dry form. But with the wet form, sometimes new blood vessels can form and you can start getting some swelling, which we can see on exam and on those OCT images. And if it gets to that point, that's the point where we intervene and start doing injections or lasers to the eye to try to help the patient keep what vision they have.
Okay, all right. I know that's kind of off topic.
No,
maybe
but
next
very
time
similar.
we can talk more about that.
Yes.
So in this image here, sort of a cross section of the eye.
Correct.
And the macular would be in the back?
Correct,
or
yeah.
I should say on the bottom.
Right, on the bottom. So it's kind of hard to see, but at the very bottom of that eyeball there's kind of a little divot there. That's the macula. And next to it, where those blood vessels are coming out, that's the optic nerve.
Okay.
And that's where it connects to the brain.
Ah, okay. It almost looks like electrical wires coming in.
Yes, exactly.
And I guess in a sense it is.
Exactly.
So, but the other divot, the one that's like dead center.
Correct. That's the macula.
Okay. And what is that doing? What does that function of the macula?
So lots of the photoreceptors, the cones, the cells responsible for our very fine, detailed central vision, they're highest density in the macula. They're scattered throughout the retina, but most high density right there in the macula.
Just in that little area?
Correct.
And then that feeds information to the optic nerve?
Exactly.
Okay.
Exactly.
And is this a laser treatment or laser cutting?
So this is a schematic that describes kind of the bread and butter of every retina surgeon's surgery, called a vitrectomy, where we actually surgically remove the vitreous jelly. A lot of people don't know this, but you don't need your vitreous jelly. You can remove it without any problems, and that's usually our first step to doing any retinal surgery. The eye fills it right back up with fluid and survives just fine.
That's amazing.
So yeah, so we make.
I wouldn't think that.
I know. So we make 3 little incisions on the white part of the eye. The first incision is to fill the eye up with saline so it doesn't collapse as we're working.
Okay, I was going to ask that because,
The second is a light, so we can actually visualize what we're doing.
Yeah.
And the third is either a cutting instrument or a forceps or whatever other instrument we're using to perform our surgery. And then using a microscope, we visualize what we're doing to do the surgery. So in the case of macular holes and macular puckers, we remove that vitreous jelly. For the macular puckers, we just visualize that scar tissue, peel it right off the macular area.
That's amazing.
For the macular holes, we peel the innermost layer of the retina, the internal limiting membrane, and that relieves some of the traction that's forcing that hole open. With the macular hole surgery, we fill the vitreous jelly up with a gas bubble at the end of the case. And what that does is it serves as like a balloon to help flatten that retina and help that hole seal.
Okay.
The gas bubble takes about 4 to 8 weeks to go away on its own, depending on the gas that we use. And so the patient could expect to have very blurred vision until that gas bubble goes away.
Any pain?
No. It's a very painless surgery, similar to cataract surgery. They do use drops for about a month after surgery. And about 85 to 90% of the time, we're able to get that hole closed.
Wow.
Now, how much vision they get back kind of depends on how big the hole was to begin with and how long it's been open. So if anyone has any problems with their vision, it's pretty imperative that they get to see us sooner rather than later, because the longer the hole stays open, the less chance that they regain useful vision once it's closed.
Okay, so again, if someone comes in after a certain age and gets their normal once-a-year eye exam or whatever it is, and they're not having any real problems, is that going to be part of the procedure for you to start looking for that as you would anything as we age?
Sure, absolutely. It depends on their vision, it depends on their symptoms. When I look into a macula, because I look at them every day very closely, I would be tipped off if there's something like this going on. The important thing is to get your eyes dilated very frequently, because a lot of times our good eye will compensate, and someone may not realize that they have a problem because we walk around with both eyes open and don't routinely close one eye and then the other. So they may not notice they have a problem because their good eye's compensating. When they come into clinic and we cover one eye to check their vision, that's when they realize, oh, darn, I can't see out of this eye, and they may not have realized before. So it is definitely important to come in and have routine checkups as you get older.
All right.
As you accumulate birthdays.
All right, very good. Thank you very much, Doctor.
Of course.
Pleasure
it was a
meeting
pleasure to meet you. Look
I
forward
really
to
appreciate it.
Talking again soon.
I know we'll see you back here for sure sometime.
Absolutely.
And say hi to everyone over there for me.
Will do.
Great people over there at Harvard Eye Associates. We'll be right back.